Okay, my name is Barry Willer, and I am a co-chair of the Special Interest Group on Concussion and Mild TBI for the International Brain Injury Association. As part of that special interest group, we've decided that we want to hear from some of the top people in the world who know about concussion and can educate us. And this is our inaugural webinar to that effect. And so we're extremely pleased to be kicking it off, and perhaps even more pleased to have as our inaugural speaker, Anthony Kontos. Dr. Kontos, list of accomplishments on his CV you saw in the document that went out advertising this. I won't repeat that. I just want you to know that, well, the University of Pittsburgh has just simply been an amazing leader in the whole field of concussion. They were doing work in this area before it was fashionable. We've always looked to them for leadership, and then they recruited Anthony Kontos as their director of research. And it's, as a friend of mine always says, the rich always get richer, and they did. That's Anthony has made them richer. His work, his research has been outstanding. And I was recently particularly impressed with the work that they were able to do with the pandemic, the research related to the effects of the pandemic, the adjustments that they had to make through telemedicine and so on. And I thought, along with Nick Reed and others on our committee, that this was just an excellent topic to start with. So Anthony, I will pass it over to you, and with great thanks for being our inaugural webinar speaker.
Thanks, Barry, for the kind words, and also thanks to you and Nick for setting this up. Appreciate it. And I'm going to go ahead and share this. Hopefully this will all go off without a hitch. Are we looking good?
You are looking good.
All right, outstanding. You know, as Barry mentioned, I'm the research director at the UPMC Sports Medicine Concussion Program, and also a professor in the Department of Orthopedic Surgery at the University of Pittsburgh, and been fortunate to be here for the last 12 plus years. And obviously the last 2 of those have been shaped, just like all of our experiences, by COVID-19. And so I'm going to really talk to you today on something that's fairly new. This isn't my usual presentation, so it's focused on our work recently that looked both at the effects of COVID-19 on concussion and also some of the opportunities therein. So kind of like a challenges and opportunities associated with that in regard to telehealth or telemedicine. Some quick disclosures. You know, I've written a book. I certainly didn't become rich from writing that book, as we all know those days are past, but just want to acknowledge that conflict for royalties, and then conflicts there with the funding sources. But I will not be focused on any of those projects in this talk, so there's no direct conflict here. So what is the goal of the talk today? Well, first and foremost, I think it's important for us to kind of step back and to provide some context for the whole idea of concussion in the time of COVID, and how COVID is very similar to concussion in many ways, at least the long haul psychological and neuropsychiatric symptoms. Also want to focus on the findings from our new study looking at what does concussion care look like during COVID, and sort of what do the patients look like and what's going on with them. And then finally, focus kind of on the opportunity of telehealth or telemedicine to provide care moving forward. And it was something that we did not really use at all prior to COVID. So this really jump-started things for our clinic, and I think for clinics across the country and world, and really has changed the way in which we deliver concussion care. So we're going to start out on I guess, a somewhat more challenging note, pun intended, where we focus on the challenges associated with COVID and how it relates to concussion. So I think first and foremost, I just want to, you know, kind of review briefly what COVID really is with regard to the brain and how that may relate to what we see in concussion. And so COVID, as we all know, can involve, you know, CNS dysfunction. There's some suggestion in the literature that there's some neuroinflammatory and cytotoxic pathways, very similar to what you see in the concussion literature from a elevation in NFL, neurofilament light protein, or GFAP. And we hear a lot of this in concussion as biomarkers, and we're actually seeing a lot of this come true in the COVID brain as well with regard to neuroinflammation. Now, That leads to the next question is, are the symptoms, kind of similar? And we see headache, dizziness, fogginess, memory problems, the issues with taste and smell, and certainly sleep is disrupted and there's cognitive dysfunction. There's something really referred to as brain fog that affects a lot of patients following COVID. And that sounds very much like what we see in some of our patients post-concussion. And something to note is that although these symptoms can be consistent and present in a systematic manner, and we can kind of categorize them, each patient is very different. I know when I had COVID, I lost sense of taste and smell and had just really the sniffles, but those were the only real symptoms that I had, whereas other people have very different symptoms. And so again, there's a lot of variability in this injury or this condition, much like there is with the injury of concussion. And so that kind of leads to this whole notion of brain fog, as I mentioned earlier in the previous slide, and how similar that is to what we call cognitive fatigue. And that the parallels are uncanny. The confusion, the difficulty focusing, concentrating, paying attention, a feeling of being really slow or easily distracted, and reports of memory difficulties with accompanying fatigue and exhaustion throughout the day. It sounds very similar to our patients for concussion that have cognitive fatigue. Now, when we look at COVID, it's also important to consider the mental health aspects and how that also has driven health behavior. And we've all heard, and it's been shown in the literature, the increases associated with both getting COVID as well as in the general population. And so just in the general population right now, the milieu of existence for our patients is one of stress, anxiety, mood changes that have really driven health issues in the population associated with the concerns over the pandemic. And in those with COVID, who have had COVID, 1 year after being infected, nearly a third of them are at a clinical level of anxiety. These are not just reporting anxiety, but rather at clinical diagnostic cutoffs for anxiety, 10% at PTSD, and a lesser number there with mood disorders. Now, there's a reason for this, right? It's not just organic and biologic, but there's also a decrease in coping and social support that is accompanied everything associated with COVID, including the lockdowns and restrictions that limited many of the activities we took for granted, including sports, but also activities such as work, school, and all of the social and family gatherings that occurred. I know my mom passed away during COVID, and we weren't even able to have a normal funeral. And so all of the normal mechanisms we go through in life were really kind of clamped during COVID, and they're only recently really returning to a more normal status. And this is also, the COVID has also resulted in sort of measures that were designed to protect us, everything from social distancing and masking to restricted activities that limited access to care and actual care seeking in non-urgent health issues. And so this really kind of made us think, does this happen also with concussion? And so first we wanted to consider what are the symptoms of concussion, how do they relate to COVID? And here we see very similar symptoms that you all are well familiar with, so I'm not going to go over, but these could just be transplanted right over there to the COVID slide, and they would seem absolutely appropriate. And again, just like the COVID symptoms, as we all know, they're highly individualized. They can be inconsistent even within the same patient. So even though there's some systematic ways to evaluate and group these, we know that they're highly individualized based on the patient, what they bring to the table, et cetera. So this kind of led us to think of, what is the overlap in these things and how do we discern this? And this is real critical in care moving forward. And I think some of these are pretty obvious to COVID, and they're not going to have as much spillover to concussion. And again, I won't go over everyone on here, but the standard physiological symptoms here are definitely distinct to COVID. The loss of taste and smell is reported with concussion and mTBI, though it's somewhat rare. So I put it over here for categorization sake. And similarly, some of these may occur with COVID, but they're much more common with concussion. Balance issues, vision, some of the sensitivities there, and also personality changes and irritability, which tend to not occur in COVID until the longer, later stages. But this is where we see just tremendous overlap. The headache, the dizziness, the nausea, the cognitive issues, anxiety, and sleep disruption, mood, et cetera, where it's really hard to extricate what are we looking at when we look at this patient across from us how much of this is driven by a previous exposure to COVID and the subsequent downstream effects versus a similar exposure to a concussion. And, our model, and I know Barry and others have published models that are equally valid. And, this is just our approach. And when we look at concussion, we all agreed to this back in 2015 that, look, concussion involves diverse symptoms and impairments, and really each of those kind of drives a profile and recovery trajectory. And interestingly, we could apply this exact same thinking to COVID, where you just replace the word concussions with COVID, and it's characterized by diverse neuropsychiatric symptoms and impairments in function, resulting in different profiles and trajectories here. And I think the two that maybe lend themselves most to our discussion with concussion are the anxiety mood component and that cognitive fatigue component, which is very analogous to what is being referred to as brain fog in COVID patients. Another thing to consider is, concussion, much like many health conditions, fights dirty. It magnifies pre-existing issues or conditions. And so if you have, a history of anxiety, either familial or personal, that's going to drive you down an anxiety mood pathway. Similarly, histories of migraine or motion sickness would drive you down a migraine or vestibular pathway, respectively. And this is kind of a more in-depth illustration of that and some of the recent literature that really shows the evidence of, hey, if you have this, you bring it to the table, you're more likely to develop this and have more substantial outcomes associated with that particular profile. So then the question really is does this happen with COVID? And so one of the things that we've really focused on recently in both our research and our clinical work is to understand better the patient's sort of COVID history as they walk in the door. And I think this is something that isn't out there in the literature, but something to talk about. And that's that, we really need to assess COVID in our concussion patients, both from a clinical and research perspective. So we borrowed, and actually we're asked to do this for our NIH grants. And so we've now kind of expanded that work to include our other grants, as well as our clinical registry and other work. And we're really focused on, hey, have you had COVID? And if so, then some follow-up questions. And then we're also finding out if they've had the vaccine, which, believe it or not, we get a lot less responses to that question than we do whether or not they've had COVID due to all the politics going on in the world these days. But what we're really focused on here is, have they had that exposure, and does that influence outcomes? What we're not getting at in these questions are the granularity of what types of symptoms, only that they're still having symptoms. And so again, there's probably more questions, but we're trying to keep it brief so we can just get an idea. And moving forward, all of our research projects, this is something that we're going to be considering, analyzing, and hopefully reporting any differences on that we may find. So in summary, just for context now, this was just kind of setting the stage for the talk, was really there's an overlap of symptoms and impairment between concussion and COVID. And I think it's pretty stark and pretty clear here. And one of the things that we want to consider is that COVID disrupted a lot of what was normal, whether it's the activities that may result in concussion or the activities that individuals return to and how they engage in those activities, much more remote working, things like that. And so that reduction in activities also, has likely led to a reduction in concussions. There's care-seeking issues. There's a reduction of coping and social support. Anxiety is increased in the general population. And all of this is exacerbated if you actually were infected with COVID. And so all of that led to, how has this really affected what we're doing in our concussion care and our patients in our specialty clinic? And just for context too, we have 6 clinics, and those 6 clinics, we see somewhere around about 20,000 patient visits a year. And so we focused on one of the 6 clinics, and we focused on around 3,000 patients to look at and get a snapshot of what do our patients look like during COVID compared to before COVID. And so this was recently published in the Journal of Neurotrauma as a brief report. And the focus on this is, again, what are the effects of the COVID-19 pandemic on our patients seen at a concussion specialty clinic? So this may not apply as much to emergency department or primary care or other settings, but I would also, highlight the fact that we are looking at this right now on a CDC project in the emergency department to see what does this look like in that particular care setting. So you guys have probably seen this sort of information before. And you can debate the numbers, but before the pandemic, these were sort of the estimates for sport-related concussion and its impact. Okay, so just under 4 million occur per year, just under 2 million with adolescents and children, around 250,000 that end up in the emergency department, so more pronounced concerns with those injuries, red flags, et cetera. About 1 in 10 adolescent athletes each year in the US anyway have a concussion. There's a huge cost associated with this, and that cost is actually general to concussion mTBI, not just specific to sport-related concussion. So again, this is kind of just setting the stage here, right? So with that in mind, in March of 2020, the WHO declared COVID a pandemic. We don't want to bring those memories up, but it's not that long ago. Seems like forever ago. And with that came a whole slew of state and national dependent public health measures, including mask wearing, the social distancing, and restrictions on many face-to-face or in-person activities, especially early on. As a consequence of that, Rosenbaum and other colleagues have reported in JAMA, New England Journal of Medicine, and other journals that patients really stopped seeking care for non-urgent conditions. So if you didn't fracture something or have myocardial infarction, you weren't really going to the emergency department. You weren't going for sprains. You weren't going for sniffles unless you thought you had COVID, et cetera, et cetera. And the question is, does this also apply to concussion? So we didn't know what our concussion patients were going to look like pre-pandemic compared to during the pandemic. Did they wait longer to seek care? Were they coming in different sort of manifestations or different mechanisms of injury? And we know that this care seeking is critical. We know that if you wait to come in to see a specialist for this injury, you're going to take longer to recover. And I'll kind of highlight some earlier work of ours on the importance of early specialty care from a published paper in JAMA Neurology from 2020. In fact, this came out weeks before COVID. I remember we were all excited about this paper, and then within a few weeks, we were all wondering if we'd ever see patients again over the next few months or however long the pandemic was going to last, not foreseeing what it has turned out to be. So our study that we ended up doing initially to look at the effects of time since injury to getting into clinic looked at 174 athletes, 12 to 22. And what we really focused on is, did they get in the first week, or did they take up to about 20 days to get in? And we divided into those two groups and then looked at our primary outcome, which was recovery time per the standard consensus criteria for full return to play. We also looked at some other factors such as demographics, symptom burden, cognitive outcomes, et cetera, and how those might relate to the outcomes. So what we found was that if you came in later, you took longer to recover, and even the time in care was different. And so that's critical to consider here. And so the number of days to first clinical visit for specialty care was the strongest predictor of outcome. And in fact, you're about times more likely to have a longer recovery if you come in later. Athletes who saw care later, in fact, on average, were taking much longer to recover as we went down the road. But it was a better predictor than the common things we think about, like symptom burden, other risk factors, concussion history. But history of migraine certainly played a role with a 3.1 times odds ratio. Now, the question is, if those benefits were critical, an earlier return to sport, work, and school, that's one benefit of that, right? Getting better sooner. Mitigates some of the negative effects associated with rest and isolation that we're all aware of from the earlier work from Danny Thomas and many subsequent papers, some of which have come out of your group there, Letty, Barry, and all of the colleagues there at Buffalo, looking at active versus inactive approaches to recovery and treatment, and also a reduced healthcare burden overall, right? So it's a good thing to get in sooner. But with the pandemic, there was no sport, no school, no work to return to. Everything was remote if it was happening. Everyone was already isolated, so we weren't really going to change that. And then we also had many, concussions that just simply weren't occurring because we weren't having sports and we weren't having many of these activities that might have had exposures related to concussive injury. So with all of that as a backdrop, we decided to do a study of one of our sites where 3,000 patients were seen across 2 time periods, which I'll talk about in just a moment. And that's between March 15th, when the pandemic would have started in 2020, but looking at a pre-pandemic 1-year cohort compared to a post-pandemic 1-year cohort, or during pandemic, not really post-pandemic. So the two cohorts there, one was right up to that date that the WHO said we've got a pandemic, and the other is after that for the next 12 months. And what we were interested in is what are the trends in concussion sort of care seeking? What does it look like from an age perspective? What does it look like from a mechanism perspective? You know, how soon are they coming into injury? I'm sorry, how soon after injury are they coming into care? And some other factors as well. And again, this was published in Neurotrauma about a year ago, and it really demonstrated the amazing effects of this pandemic on our patient census or rolls. We had nearly 40% fewer concussions during the pandemic coming, and that's not surprising. We see this in all non-urgent healthcare publications during the pandemic. There's about a 40 to 50% drop in non-urgent care seeking. Interestingly, though, those patients that did come in were nearly 26 days later on average. So they're waiting almost a month to seek care. It's almost like they're hemming and hawing, and they're like, well, now I got to go in because these things just aren't getting better. And the question is, could we have mitigated those upstream if they had come in sooner? And I think the answer to many of those is of course, yes. And then we had sport-related concussions taking an absolute, basement falling out, collapsing to the bottom floor, with nearly 60% reduction as sports were all but suspended during much of this time. So if we revisit those numbers from the earlier slide, we're now down to about 1.5 million sport-related concussions per year, 760,000 compared to 2 million concussions in youth, 19. And actually, you can argue it's even, as you'll see in a subsequent slide, it's even probably lower because that was the age group that was hit the most with regard to not coming in for this injury. Emergency department visits, we'll know this hopefully with some of our newer research, but they collapsed as well. And all of this extrapolation really means that there was less of an economic impact. But as we all know, that there were other shifts in the healthcare industry with the impact. So again, it was probably mitigated or balanced out with those. So when we look more specifically in our population of study, our paper, when we look at age, what we found is overall there was about a 2-year older population coming in. But one of the things that was really interesting to look at is where were the decreases, and they really happened at the younger ages. So children and adolescents, they didn't completely vanish, but they all but vanished. So we saw massive decreases in those age groups and not as big a drops in the older age range from college on. And again, I think a lot of that also was driven by the fact that, vaccinations really didn't target these groups until much later in the pandemic. When we look at monthly trends, and it's important to note that this doesn't coincide with a time period, it looks at that early pre-pandemic period. So the January, February line for the dotted line is actually before the pandemic. So we kind of just fudge these a little bit so they'd sit on more of a calendar year. And, it's really fascinating here to see some of the different trends that we see. Of course, COVID caused a collapse in the number of patients coming in during particular months right after that, like April and May. But we also saw an explosion of sorts in the summer and that peak that we don't always see. And that was driven largely by everyone returning to activities when oftentimes we see a decrease in that during the regular year. And of course, other restrictions happening again the following November, December resulted in another fall off of concussions being seen at the clinic. Now, with all of this said, it wasn't all negative. We had a heretofore unknown sort of frontier for us, the emergence of telehealth or telemedicine. And so 10% of the patients that I've been talking to you about during the pandemic were seen using telehealth, which prior to that, it was 0. We didn't see any using telehealth. And so this was a big change for us. And it really opened our eyes and opened some doors to better care and a better reach for care out there to deal with things like disparities and rural access, et cetera. Some other findings were related to sex, as well as looking at when they came in from an early perspective. But interestingly, there were no sex differences here, which we fully thought that we'd see an increase in female patients over males. That's typical with healthcare in general. Males are reticent to seek healthcare, and we thought that there would be an expansion of this during COVID, but it actually turned out they were about the same. In contrast, patients were about 1.5 times more likely to present earlier So within the first week, which is critical to care downstream in the pre-pandemic phase, as opposed to pandemic. So very few were coming in within the first week of injury. And there was a massive increase proportionally in non-sport related recreational injuries, as is illustrated in this picture. Tons of cycling, skateboarding, playground, just kind of messing around type injuries, recreational, as opposed to organized sport, which was all but, again, halted during the pandemic. Now, in conclusion from this study, what we found is, overall, there were certainly fewer patients as we would have expected, but that was especially true for the sport-related concussion patient. And we saw later care seeking of almost a month overall, and a slightly older, a couple of years older on average, patient age for those that were seeking care. I would also highlight that we didn't see an increase in numbers. These are just proportional, right? So when we look at the older, we didn't see an increase in older patients compared to before, just they're slightly older and proportionally more compared to younger ages. Those trends combined with what we talked about earlier, fewer coping, social support, disrupted routines, more anxiety, mood, really resulted in more complex patients. So they're coming in later, they're bringing a lot more sort of patient baggage with them. The milieu around which their concussion occurred is more stressful. All of this is leading to a challenging concussion conceptualization as well as care treatment planning. So it was a very different patient overall than what we saw pre-pandemic. From a temporal perspective, I think we should be able to predict and sort of expect changes in patient flow based on these public health trends associated with pandemics. And hopefully we're not dealing with a lot of these in the future, but I think we've learned a lot about how to respond, how to size care and target it during these times. And then finally, I think these findings highlight some of the challenges, but also, the opportunities. There's accelerated growth in telehealth, and this is really an opportunity for concussion care to expand its borders and really reach a lot of those groups that previously aren't being served by concussion clinicians. And so that leads us to part 2 here. And for part 2, I'm going to focus on a little bit more positive outcomes and really looking at some of our findings in regard to telehealth for concussion. And I'll start out with a sort of review paper that we all did, and Melissa Womble was the lead author on this. RJ Elbin out of Arkansas was one of the senior authors, and Melissa's, of course, at the Inova Clinic in Virginia. And this was really born out of our work. We were saying, hey, we really need to talk and kind of spread the word about telehealth for concussion. And so first, why do we want to do this? Well, this provides an opportunity for increased access to concussion care, to reach our rural folks here in Western PA or all around the country, to deal with things like the pandemic, transportation issues, to get people to clinic. It also addresses many of the health disparities that are so much a focus right now about expanding healthcare. We also see a reduction in time commitment and disruptions for patients associated with using telehealth, and there's improved engagement of patients that are maybe too symptomatic to come to clinic, or they don't want to come to clinic because of their symptoms. So there's really opportunity here to engage those patients. And then finally, I think patients are more comfortable when they're sitting at their house. It's more convenient, and they can do it on their own schedule and their own time, much more so than they can by coming into the clinic. Some other things to consider, and I think for these, really the key here is that these are barriers, but they're all, things that we learned and processes that are evolving. There are interstate licensing issues. Now, a lot of these state laws were kind of pushed to the side with some of the COVID exceptions, but many of those have ended. And those are currently being debated in federal legislative ways to see if there's a better approach to delivering care via telehealth, because currently with these interstate restrictions, it's quite difficult if you're not licensed in multiple states. There are legal issues. You have to consent patients. There's confidentiality and privacy issues that have to be dealt with through password use, things like this. And also, seeing a red flag in person in a clinical, setting, person to person, is very different than trying to figure it out when you're looking at a screen. And so I think, that's one of the areas we have to really understand a little bit better how valid and how useful and reliable our approach is going to be to identify those things, screen or remote care versus in person. There are a lot of institutional obstacles that we didn't think about, but that came up. Everything from the cost associated with the programs to training, which was a big deal. We had to train all of our clinicians, all of our staff on how to use this. And also the EHR integration, which was, something I'd rather not talk a lot about, but pretty challenging, right? And then billing, another thing that, we don't love to talk about, but that's a reality here, is how is it billed? How is it coded? All of those sorts of things. And access, you think everybody has a smartphone and an unlimited plan, but we certainly know that that is not the case. And that's a poor assumption to make. And it's especially poor when we look at historically underserved groups for concussion care and healthcare in general. So things like internet access, data usage plans, not having unlimited plans, or not having good wireless access, all these things are critical and need to be sort of tested out before you interact with a patient. And then finally, with regard to barriers, this whole notion of applying or using our concussion tools remotely. Some things like, neurocognitive testing that can be done online and supervised and symptom inventories, those are, I think, pretty easily transferred. But one could question, what about the VOMs? What about, doing a visual exam or an overall exam in general, a neuro exam? How valid and reliable is that compared to an in-person exam? So with all that in mind, there were many solutions that we identified throughout our work, remotely with patients. And one of those was, we have to identify sort of a key gate person in our office that coordinates and assists with patients and is trained up and can deal with all the technological issues, but also all of the issues with regard to record keeping, consenting, all of these things. Pre-staging appointments is critical to minimize the disruption to the actual one-on-one, patient experience. This can involve everything from getting consent ahead of time to making sure the patient environment is set up and working and the technology is functioning properly, to many other things. And clinicians need to be flexible. A lot of these sessions are a little less, they don't go quite to plan all the time. And a lot of the things that you can do in a one-on-one clinic setting have to be, adjusted to be able to be delivered in this online or virtual setting. And then finally, the solution is that this really provides us with an opportunity to do research, to really understand, do these tools translate? Can we do things reliably and valid in this environment compared to an in-person environment? And that really led to this question for us. Does telehealth really equate to in-person care? Like when you look on the left and you see that person, in one dimension or two dimensions there, is that the same as when the person walks through your office and is sitting across from you and you're doing your exam in person and talking to mom or dad or something like that, in the exam room? And so this led us to conduct a study. And when I say us, this was predominantly done by the University of Arkansas. I was merely a collaborator on this project with Dr. R.J. Elbin and his colleagues there. I know Damon Lipinski and other of the clinicians here that worked up at UAMS and Little Rock were involved. And the idea here was a small pilot trial, a randomized control trial. So good design, but small numbers, to compare care ratings, therapeutic alliance, and patient satisfaction between in-person and telehealth care. And we had 30 adolescent patients, and they were randomly assigned to one of two conditions, an in-person visit or a telehealth visit. And again, they were diagnosed with a concussion, and this was their first visit. And we only have data for that first visit. We didn't follow them long-term or serially or anything like that. And what we wanted to look at were, both parent and patient perspectives, or caregiver, if you will, perspectives on care ratings, therapeutic alliance, and satisfaction. In other words, did they think these two environments were equitable, was really what we were getting at. And what we found was that patients and caregivers both rated both environments quite high, and the therapeutic alliance scores were not different. So that means that they viewed that alliance with the clinician as being similar in both environments. However, that was for the patient. The caregivers actually viewed the in-person sessions as kind of better. And so that's, I don't think, unexpected. I know as a parent, if you offered me the options, and I would probably perceive that the one in person was better. And again, I know with watching my dad, who's 92, get care in virtual for many of his visits during the pandemic, they've done an amazing job, but it's not quite the same thing as in person, right? And so I think there is that perception there about that therapeutic alliance. However, there were no differences an in-person and telehealth care with regard to patient satisfaction on a variety of factors here, including the depth of care, the smoothness of the delivery, the positive interactions, the arousal associated with doing it, and the outcome, sort of good and bad variation in the outcomes. In this particular slide, we're focused on the caregiver differences. As you can see here, overall, the in-person was rated, again, a little bit higher, both in the means and medians, and than what we saw in the telehealth. But the patients really saw this as pretty much equitable. They didn't see any difference. And when we look at those scores on evaluating the sort of overall alliance or therapeutic alliance here, what we see is a very similar perspective across the telehealth and in-person. So almost identical means in the two columns there highlighted in red. So what does this all mean when we kind of put it all together? Well, first, I think telehealth for concussion care is not going to go away. It's going to continue to grow. And if anything, I think it's going to benefit our field and our patients. It'll expand delivery particularly to those who are often overlooked in care delivery in in-person settings. And I think that will really help with rural and otherwise, underserved populations with this injury. The findings highlight the fact that there's a positive perception of both telehealth and in-person concussion care, and that those therapeutic alliance ratings and patient satisfaction are quite similar in the two environments. Although caregivers kind of think that it's a little better in person, they also overall reported a positive experience with telehealth care. So it wasn't viewed negatively in any way, even though they still saw in-person care as potentially a little bit better in their perception. So at the end of the day, after this talk, I like to leave time for questions here. And I have one last thought on the next slide for sort of something to consider moving forward that isn't really in any of this research that I just discussed, but I think something that came up time and again and has been mentioned in the literature. But as far as what I just said, I think it's important first that we really consider the patients across from us and the overlap of what we see from COVID and what we see from concussion with regard to symptoms and impairment, and really understanding what is related to one versus the other. And so asking those questions about COVID history, about exposures, et cetera, and then doing usual in-depth exam on concussion and all the risk factors therein, and to really look and compare and contrast and really start to extricate what's coming from what signals coming from COVID, what signals coming from concussion is really critical to good care moving forward. Now, we know COVID decreased and changed patient census in our clinic as we expect it did elsewhere. And we saw an overall 60% reduction in sport-related concussion. Now, I can tell you straight up, we have completely rebounded. We are back to normal. Our last quarter census was actually higher than our previous pre-pandemic census for the same time period. So we are back at it, much like Major League Baseball just got their stuff in order, is getting ready for their season. We got our stuff in order and we are full on, and we expect things at least in the current pattern, if it holds, to maintain and to continue to grow as it has this past quarter. But in the pandemic, later care seeking, older patients, more non-sport concussions, which was expected. COVID resulted in both challenges and opportunities, and I think that opportunity for telehealth is massive, and it can really help, as I mentioned on multiple occasions, address disparities and really expand our reach with this injury and the care we can provide. Initial evidence suggests that they're pretty comparable. I wouldn't say they're exactly the same, and I think there's still a lot to be learned about what can we do telehealth that we can't, what can we do in person that we can't do in telehealth? What doesn't transfer? And are there other strategies that we might be able to use in telehealth that we don't currently use in in-person care that could help deal with some of those differences? Now, this is the thought that I had to end the lecture after that nice sort of take-home message piece. And this is really something that kept coming up during our work, and that recently Darcy and colleagues in a paper in Frontiers in Neurology intimated, and that's that concussion care paradigms really provide a template for neuropsychiatric symptoms and long COVID management. And I can't speak for other clinics, but I know this is not something that we are currently doing, but it is definitely a potential area of growth for neuropsychology and in general for care provision extension of what is applied to concussion currently that could potentially be relevant in application to COVID patients. For example, the way in which we contextually frame outcomes and care for concussion, it's very focused on driving a positive, hey, you're going to get better. This isn't something to be scared of. And these are the things we're going to do to help you get better, giving the patient some of the reins with active strategies, as you all are well aware of there in the Buffalo group, working in active aerobic exercise treatment strategies, et cetera. And then really laying a foundation of behavioral management that includes not only physical activity, but sleep, stress management, a focus on obviously nutrition, hydration, things like this. That's a positive thing that can certainly help those individuals post-COVID as well. The approach from concussion that involves multi-domain screening from neuromotor, vestibular, oculomotor to cognitive dysfunction, as well as emotional related issues. All of that really is critical here to better understanding at-risk patients following COVID, and also the prognosis for them and how we might inform earlier intervention. And the last 2 points I would make is that, and they were made in this paper by Darcy et al., is that the multidisciplinary approach to concussion that is currently advocated whenever possible, whenever resources allow, to treat concussion in the most effective manner is really the same one that's being advocated to treat long COVID and some of the neuropsychiatric consequences of COVID exposure. And this lends itself to those more targeted active treatment strategies to hit each domain rather than trying to do an across the board one size fits all approach. So with that said, a lot of acknowledgements here, and I want to thank everybody that's contributed to our research, from my staff here at the lab to our clinical faculty who allow us access to patients, and our fellows that support a lot of this work, as well as my colleagues, as I mentioned multiple times, from the University of Arkansas and Innova Sports Concussion Clinic. And so with that, I want to thank everyone for your time today, and I think we have some time for questions. I think we're right on schedule.
We are very much on schedule. Anthony, that was terrific. I wish I had some way to applaud. I can do my own, but I can't capture an audience doing it, but you would certainly get applause for that. That was a wonderful summary of the issues. I feel a little like we've been living in a parallel universe here, because so many of the things you talked about were things that we've seen here in our clinic and in our research, and it was just maybe not as well articulated by us, but certainly we've seen what you've seen, and I really appreciate your ability to describe it, especially with some data. So again, very well done, very nicely summarized. I do have a number of questions to bounce off of you, more as a discussion point, I think, because as you very aptly pointed out, we're really into some new areas. That notion of treating long COVID using some of the skills, some of the learning that we've done in concussion, that is a really interesting observation. And we've actually been talking to some groups here about doing the same sort of thing. I guess I'd like to think out loud with you about some more of the ways in which we think it might apply. I do want to make a point, though. Like you, I've probably been following it with a lot of interest, and it's interesting because I think the long COVID is facing some of the same issues we faced in the early days of concussion, where people are essentially denying that this can be from the disease. You're 3 months post COVID and you're still complaining about foggy thinking. I'm sure you're fine by now, or whatever. And I've seen interviews with people where they're saying that, and I just think back to the days when people with concussion were being told, well, there's really no reason for you to be feeling this way. And by the way, your cognitive issues don't show up in any cognitive testing that we might do. So obviously it's all in your head in a different sort of fashion. Anyway, getting back to the treatment of that, I don't think any of us can say we have much experience with that. We certainly can't. But your thoughts about how it might apply, I think, are really good. Have you written that up in any way, or is it just
No, it's one of those, I think we're thinking out loud all the time and adapting. And, what's interesting is, what I can share is that we've submitted several grants to look at, and compare and contrast, what is COVID long haul. There's a million words for that, but we'll just call it COVID long. And some of the neuropsychiatric outcomes associated with that compared to, cohorts that don't have COVID, haven't been exposed, and just have mTBI or concussion, and look not just at the clinical outcomes, but also looking at their brain, looking at the MRI, the DTI, the FMR, also looking at, some of the biomarkers, the fluid biomarkers, and really get a in-depth dive at how do these patients differ. And one of the things that struck me is the same risk factors we talk about concussion, what you bring to the table, like the anxiety, the motion sickness, the migraine, the sort of trifecta of doom, if you will, that you're going to have a rough patient recovery, are the same ones that are reported in the New England Journal of Medicine, JAMA articles, Lancet on associated with negative outcomes and longer symptom recovery and all of that, the same stuff you see with COVID. And so to me, there's just so many parallels, Barry. And I think that, I stressed that positive contextual framing that I know we use, and I'm certain that you all use as well, where let's get this patient in a positive mindset that's going to be about recovery, about active, engaged rehabilitation, et cetera. And you don't see that with a lot of COVID patients. It's much more of a mitigating fear about, potential prognoses that are not positive, and a lot of, like you just denial of these longer sufferers. And I think that this is all a disservice to these patients that really doesn't help them get on the pathway. I think we've learned our lessons. 20 years ago, we were in the same boat, and things weren't being dealt with the way they are today. And 20 years from now, we'll look back at now and probably chuckle as well, right?
Yeah. Just really, really appreciate your insights on that. Also appreciate your experience with telehealth, and we also have been doing that, and I noticed a few of the people asked questions about it. What if you could identify some things that just don't seem to fit well with telehealth, what would they be? Because I think overall there's some advantages. We saw people more likely to follow up because, of course, they don't have to come into the clinic and so on. So there were some advantages, but let me give you an example of one we ran into. We found that we're looking at doing a physical exam, and you guys have so much experience with the VOMs and so on. There's some things, particularly with ocular motor examination, that were pretty difficult to do reliably on using Zoom or some other technology. Is that similar to your experience? Have you looked at that at all?
Yeah, we did. And we haven't, it's something we've talked about, trying to collect data on and really compare. And I know RJ down in Arkansas, similarly, the VOMs, there are some that are working better. The vestibular components, which are the ones that tend to provoke more symptoms today, so the VOR, VMS, those are a little more, I think, telling in the telehealth. In contrast, we look at saccades, when we look at having the patient do the near point, the angle and the flatness of it, there's all, you're not seeing maybe the nystagmus things going on with some of the movements and some of that. But I think overall, they're certainly not the same, and there's some issues there. But we're still, with regard to symptom provocation, I think you can get at that. What you may miss is a little bit more on the physical findings or the objective, what you're seeing with the patient can be a little bit dependent upon the angle. One of the things, though, that I think is a big issue, and we've seen differences on, is the particularly with the adolescent patients, is kind of that dynamic with the parents. It's very different with the caregiver. Like this, especially when they're engaging, like off and on, or hey, your mom or dad should leave the room, that kind of stuff. There's a lot of sort of back and forth, and it feels really artificial, some of the responses, and there's a lot more sort of I guess holding on to some of the truth of responses where they want to say something, but you can tell they're looking back and maybe not saying it. And you get that in a patient room too, but we miss a lot of that dynamic and that behavioral piece. But again, a lot of that's dependent on the environment in which the patient is engaging in the care.
Yeah, that's very interesting. Did someone else have a chat comment there? Did I see? I'll try and sort that one out in just a moment. I really found that interesting in your research with albeit with a relatively small sample, but that notion of the patients feeling that there was therapeutic alliance, but the treaters didn't feel that way, or not necessarily. I may be oversimplifying it, but it was a very interesting observation.
Yeah, it's the parents, the caregiver. So not the care provider, not the clinician, but rather the parent that didn't perceive it.
Oh, I missed that then. Okay. So is that possibly just an age difference? I think about my grandchildren and how incredibly comfortable they are with technology.
We were almost, I think, 80% female. So these are mostly moms.
Yep.
And to be honest with you, they were randomized into the study. They agreed to do it, but I always feel like sometimes they go, yeah, I'll do it. And then after the fact, they're like, well, this doesn't seem as good as the real care, or, something like that. So there may be some of that creeping into it, but I also do think you're right. There's probably different perspectives in an adolescent, which was, I think I did that, but that's who these patients were. And they're much more attuned to this world, and especially post-COVID, this is normal. Yes. So that, it's no big deal. Whereas most parents, caregivers are probably a little less, engaged in this type of environment, a little less happy with it as a therapeutic, delivery vehicle.
I'm just going through this question. So one of the key things we've noticed in our work with both concussion and long COVID. Oh, this is somebody that's working with both. This is Matt Dodson. Okay, good for you. Much more variable day to day. While helpful, are fatigue management tools and compensation strategies for mTBI don't translate as well. Have you seen a similar phenomenon? Well, I guess like us, you haven't had that much experience with the long COVID, so it's probably Matt's probably got better observations than we do.
That's a great question. We are not have not expanded our care, to treat these patients. I think it's more in a consultative role that I would envision anything moving forward, where we're working with others who specialize in post-infectious disease, neuropsychiatric care, which we saw this with people that survived things like Ebola and other exposures, where they have long-term psychological and neuropsychiatric issues, neuromotor issues, and how do you deal with those? How do you treat those? But I think COVID is playing catch up with that. And as you mentioned very earlier, there's not a good, there's not a good recognition or really even like acknowledgement of this, and some denial of it in some clinicians and others. And I don't think there's a clear therapeutic pathway for it yet, but I think it has to evolve. I mean, I think we have to be considering this moving forward. Who are these patients? How can we help them get better? And who's at risk moving forward in this and future pandemics for these kinds of outcomes?
Am I being too cynical if I think that it's got something to do with insurance and
probably does? Yeah, always does, right?
So Nick has a question. He says, from your experience with telehealth, are there some aspects of care delivery that work really well? We didn't really emphasize that. You talked a little bit about that. Can you expand a little on things that you thought went well?
Yeah, so you maybe wouldn't think about it, but the rapport, trust, and sort of that initial connection on the telehealth was very strong. This is, again, we didn't examine that, but anecdotally, like our clinicians talk about how quick they can get into it with the patient in telehealth. It's a very quick connection. There's a nice rapport that you wouldn't expect from telehealth. I also think patients are a little more forthcoming with symptoms. in telehealth. Again, this is anecdote. I don't have evidence for this, but I feel like they're more comfortable, just like some people are more comfortable presenting, in this environment. I actually don't like it as much because I have to sit down, and I never like to sit when I present. But other than that, I get that it's more comfortable for patients. And I think that allows them to be a little more forthright, forthcoming, perhaps a little more insightful. And there's not the disruption of getting into the car and driving and all the things that might actually exacerbate their symptoms, especially if they have like vestibular issues and they have to drive themselves to clinic. And there's been some recent research showing that there are issues potentially that could affect driving ability post-concussion, and something to consider. So yeah, I think it's some things do work better, not all, but I think most of it at best or at worst, we're trying to make it even, right? To make it at least equitable.
One of the things that has struck me, partly because of my own experience, I've done a lot of work in New Zealand and Australia. And in Australia in particular, they have a lot of people who live in very remote communities. And they've been doing telehealth long before COVID, and not necessarily offering concussion-related services. In a couple of months, one of our next speakers is going to be Mike Ellis, who has been doing this in Manitoba. And he, as part of the commitment to the funding source, namely the province of Manitoba, he has to provide services to a lot of remote communities, and he's been using telehealth for that, and has published on that, and has demonstrated that for the most part, he can accomplish just about as much with telehealth as he can in person. So, and worked out some techniques for doing that. So that's a little advertisement for a couple of months from now. But I'm with you, Anthony. This is going to be not just a reaction and an adaptation to COVID. I think it's going to become part of our standard procedures before too long. We are pretty much at the end of time. I asked my co-chair for this group, Nick, to maybe have the last word. I will close my part by saying, Anthony, thank you so much for doing such a wonderful job and being our inaugural webinar speaker.
Thank you, Barry.
Thanks, Barry. And yes, I will echo those words as the co-chair of our IBIA Concussion Special Interest Group. Anthony, thank you so much. That was absolutely fantastic. So timely, so relevant, but also so many implications for the future. Thinking about telehealth, thinking about long COVID, and how we in the concussion space can support both those with concussion, but perhaps those with other conditions and needs along the way. So huge thanks, but also a big congratulations to you and your team and everything you've accomplished in this area, but all areas of concussion, true leaders in the space. And as Barry said, we couldn't be more thrilled to have you kick off our speaker series. So huge thanks. I'll just make mention as well, thank you to those who carved out time to join us today. We really appreciate it. And Barry set the table a little bit for the future, and we do have a couple more sessions coming up. Our next one will be on April 20th at 11 a.m. Eastern time. So all those out there interested in all things concussion, keep it on your radars, put it in your calendars, and we look forward to having you come visit us again. Without further ado, Anthony, again, thank you so much. We really appreciate it. Good luck with your work. And if any of us can support in any way, we are here.
Thanks again, Nick, and thanks, Barry, and thanks to everyone for setting this up. It was my pleasure.
Thank you all. Have a great rest of the day.
Bye.